I'm Richard Taylor and I'm here on Jesus Green in Cambridge, and I've just been to a meeting run by the Cambridge Commons organisation discussing health inequalities in the city. Now, that life expectancy difference between one of the poorest wards of King's Hedges and the richest wards of Newnham is an astonishing 11 years, and there was a discussion about what could be the causes and what's behind that. Now, one thing is simply money. If you've got money, then you can afford a decent place to live and you can afford to heat that place, for example. And if you're in a nice environment, then your life span is going to be longer, and you can have more. It's not just about lifespan, it's about the amount of time that you have in your life where your life isn't impacted by serious disease or disability. So in King's Hedges, for example, a fifth of people say that their health is poor or very poor, and that is lower in other parts of the city. Now, what are the things that aren't just down to money, which impact people's lifespans or impact people's health? Well, one of them is perhaps food. This is just my suggestion, one of the things I've been thinking about while listening to the debate. Now, how do you learn about how to have a good diet? Now, probably a lot of that comes from your parents, and if your parents don't know, then that doesn't come down to you. Now, really, schools should be a great equaliser, and perhaps schools should be doing more to educate people and inform people about how to live a healthy life. Now, I'm sure some of the extreme cases of malnourishment or people who are children who are not getting meals at home do get picked up by teachers and by social services. But what about the vast majority of people? What about the majority of people who are perhaps living in places like King's Hedges? And now, it's really difficult, of course, to have this to say these kind of things. Like, I didn't finish my sentence just then, because what you don't want to do, what I don't want to do, is say that people who live in King's Hedges, and I live in King's Hedges, are stupid and are making the wrong decisions. And so that's why it's a really difficult area to start to talk about when you start talking about people's diets, because you then get into the whole question of individual choice. Now, of course, people aren't going to be actively, intentionally making choices that are bad for their health, but perhaps they are making choices to do things which perhaps they don't realise are bad for the health. And I was also thinking about what are the other things that are not entirely down to money, which impact people's health. And something the report by the Cambridge Commons mentions is social class. Now, how can social class impact your health if it's not directly through money? Well, I was thinking, is it something like how pushy you are? How pushy you are when you go to a GP? Like, perhaps do people from some areas perhaps have a tendency to just accept what the first GP says to them, perhaps after meeting them for the first time, and just after 2 or 3 minutes giving them a diagnosis, whereas maybe someone in a richer area in Newnham might question more, might talk to their educated friends, might demand a second opinion, might demand a referral to a specialist. Perhaps those are some of the reasons. I think we need to investigate what those reasons really are. Now, there's lots of variation around the city, I know, in the quality of GP practice, for example, and the best ones are in the richer areas, and those who live in poor areas can't access them because they have such small catchment areas. Now, perhaps that's something that we might need to address. And actually, why are there those big differences? Why can't we perhaps move some of our GPs around and share the good practice and share what we've got in the city in the richer areas with those areas which are poorer? Somebody speaking at the meeting, it was a public meeting, lots of people made contributions, said that they didn't think that there would be much knowledge and understanding of the degree of health inequality in the city, and we should do more to talk about it. Well, I think we should do more to talk about it, but it is something that gets discussed quite regularly at council meetings. It's in the pages of the Cambridge News quite a lot. It gets discussed a lot, but how much of that does really get into people's minds, and are people really thinking about that when they choose elected representatives to run housing at the city council, to also run public health at the county council? I think we always need to do more, and I try and do what I can to open up what's being discussed about essentially public debates in Cambridge, and this is clearly a really important one. So why I'm doing this video now, why I went to the meeting this evening.
My idea is that Tony will speak first, and then Julian, and then they'll engage in a kind of dialogue between them, and everybody should join in. Okay.
All right, good. Thank you very much, Stuart, and welcome everyone. As Stuart says, I come at this as a retired public health doctor, who's had a very long interest in inequalities throughout the 40-odd years I worked in the health service predominantly before I was in the Welsh Government. I started my career actually deliberately in Tower Hamlets as a GP for 10 years in something called Poplar, if people know where the Blackwell Tunnel comes out. Built a health centre, a teaching research centre that actually has now delivered some real reductions in inequalities in Tower Hamlets. So we could talk about that if you want. This is a really good model of using health services to try and reduce something that is largely determined by social factors. So I speak tonight really as a retired pensioner who happens to be resident in Cambridge, and I'm not speaking on behalf of Cambridgeshire County Council or City Council or Commissioning Group or anyone else, so I'm just speaking as an individual. And I'd just like to make some reflections on the excellent report that Stuart and I have done, because actually I think they've pulled together some of the issues in a very coherent way. One of the most recent reports, Stuart commented on the Black Report. I mean, he actually went further back, and of course, Dickens and Simon in the mid-19th century. So poverty's been around for a while, but in terms of the modern period of public health policy on inequalities, I think I take the Black Report partly because it's part of my time, and I still have 2 or 3 copies of the cyclist-style report, which I went out and got from HMSO and Holborn, so I hold it, and maybe it'll be worth money sometime. But they were the, in 1980, published, this was the attempt by the government to essentially bury the Black Report. But that basically laid out the facts that health was determined largely by social economic factors, and that there was a gradation between social class 5, 4, 3, 2, 1. And that's gone through many iterations, most notably in 2010 by Michael Marmot, and the title of his work was Fair Society, Healthy Lives. And I just say that to you because part of the point about this report is actually health is not necessarily just a good in its own way, it's actually better for the economy and better for society in general. So part of the thesis of people like Wilkinson and others is that healthier societies, fairer societies are also happier societies, more productive societies. And I think there are places like Denmark in Europe where year after year it's reported as the happiest, healthy country. And that's largely because they have social policies that support mothers and young children, early age care, schooling, health, and so on. So, and workplace, and very few. Owner occupation in Denmark is relatively low. Tenancies are secured. Their expectations on landlords' rents are relatively low. So, some of the things you talk about here actually are acted on in other countries. So, the other thing that I think the report pulls out that's always been close to my heart is that this is an issue of social justice. And I've often, when I was Director of Public Health in Peterborough, I remember being asked by Radio Cambridgeshire, because I produced a similar sort of maps, but across Peterborough and East Anglia. And they said, oh, well, if we get in a car from Peterborough and drive to Cambridge, then will our life expectancy suddenly increase by 11 years, So I had to point out that road traffic accidents in Fenland and stuff are extremely high, and that wasn't a smart move. But social justice is, I think, a really important point, because I often reflect on what do you need to do in the criminal justice system to have 11 years of your life taken away from you. What exactly do you need to do? Because that's actually the difference within Cambridge life expectancy between people living in one ward of Cambridge and people living in the other. 11 years different in life expectancy. So just reflect a bit on when you read the newspapers about manslaughter, murder, armed robbery, GBH. What do you need to do to deserve that? And people get that at birth, essentially. Because your life chances are determined in the early years, and part of Marmot's work has been you've got to give everyone the best start in life, and that's all about pregnancy, early years, preschool years as well. So think a little bit about social justice. And in Cambridge, one of the reasons that I was quite happy to provide some advice, and that's all it was for this report, it just feels scandalous to me that in Cambridge in 2016 we have this inequality that we've known about for a generation as well, for certainly since the Black Report and before that, so that's 35 years. So why is it that a city like Cambridge, a relatively small city, we've still got this stuff that I was reporting about 15 years ago? And it's been one of the things that's really bugged me as to why we can't reverse this. So what do you need to do? And I think Stuart's other point was, I just mentioned life expectancy, but it's also disability-free years, because if you look at the Marmot data, it's actually people become disabled earlier if you're poorer, and that actually you don't live much beyond retirement age, so you actually don't benefit from your pension because you die. But you've probably spent about 17 years being quite disabled, that your life has been limited by disability or illness. So I think it's disability and death, but what do we need to do? And Cambridge, the opportunity is with us now because the economic growth is 7% growth. Companies like ARM, we noticed the other day, what was it, £27 billion sold. We can see all this development of housing going on, yet not with affordable housing, as I think the report points out at Rustlat Road. The affordable housing planning constraints just appears to be ignored. I mean, what was it, 8 affordable flats out of 143, the ones around the station. So that's an example of social policy that's not being enacted. As we know, affordable housing is a real problem in Cambridge. So this Cambridge phenomenon, I think, is a fantastic opportunity for Cambridge to actually take on board the fact that we want a fairer Cambridge, a healthier Cambridge, and Cambridge that continues to expand through its research centres and so on. So if we take something like Michael Marmot's Fair Society, Healthy Lives, just 6 things that they recommend. The first is to give every child the best start in life. So we've got to think about this in terms of a life course. So the first thing is think about pregnant women, mothers, young children, preschool. We've got to give them the best start in life. And that's why things like Sure Start were introduced, and why it's shameful that you're seeing so many children's centres closed in Cambridge. The second thing was to empower children and young people so they can get control of their lives. So this is something about people feeling empowered to control their lives, especially young adults. I'm thinking about people like NEETs, people who are not in employment, or training. And if you've got lots of building going on in Cambridge, you've got a skills gap, why aren't you having training, apprentices, especially targeted at local Cambridge people rather than importing people? So empowering young people. The third one is fair and good employment for everyone. Mentions being made by the 2 stewards about the low wage economy, 0 hours contract and so on. And lots of the children in poverty are actually with one of the adults in the household working. And so that gets on to the fourth one, which is minimum income for healthy living. And that's obviously something that needs to be re-evaluated regularly, but people need to be able to earn an income that allows them to live a healthy life. The fifth one was about developing sustainable communities. And so part of this is not isolating rich people from poor people, it's not making no-go areas for people, it's to develop Cambridge with healthy, sustainable communities. And then the final thing is about health prevention. And that's where the NHS and social care and other voluntary sectors actually can make a difference to make sure that people get access to prevention, because that will make a difference, and that's something that actually the Commission Group and others should be interested. I come from, a GP, public health background, and I think if you're thinking about health services, then integrating public health prevention with primary care is the way forward for health. But that, after all, is only one of 6 things. And so the strategy for the future needs to be intersectoral, a joined-up strategy, national government, local government, NHS, public sector, university, as well as the voluntary sector and people themselves. So, welcome the report. let's make use of it. There's a fantastic opportunity in Cambridge to make a difference, to get Cambridge more like Denmark rather than elsewhere. So my son lives in Denmark, that's nice.
Thank you very much. Julian.
Well, thank you very much, Stuart, for the invitation to come and speak about this. And health inequality is an utterly crucial issue, one that's not talked about enough. It just doesn't quite get through too often. I have a slightly different relation. To me, I sort of grew up at home talking about health inequality, thinking about it. It really shaped my own political views, my life as it developed. I should confess part of the reason is, and it's lovely to hear Michael Marmot talked about so much, he's actually my uncle. So I really did grow up talking about this sort of thing all the time. Perhaps there were a number of times I had heard a bit too much about Whitehall studies at times, but it is something which has just always been there for me, and so those 6 things are regular things that he and I talked about, and we talked a number of times while I was an MP about how to achieve some of those things. So it's something which I've cared about a lot. It's also, and it was lovely to hear Stuart mention Joseph Rowntree. I feel it's particularly appropriate to mention since we're here in a Quaker meeting house. I'm also a recently appointed director of the Joseph Rowntree Reform Trust, so trying to carry on some of the Rowntree work. I've so far been appointed about 2 weeks, so I can't claim any achievements yet, but I hope there will be some. One thing I want to say very clearly is that, as Stuart mentioned, I've just been reselected to stand for Parliament again for the Lib Dems. I really don't want this to become a party political thing at all, partly because it's really frustrating sometimes when that happens. And I remember back in late 2010, I think it was, there was a debate about youth unemployment in Parliament. And at one point, quite a long way through, I was sort of standing towards the back, talking to Lisa Nandy, who's an extremely good Labour MP, some of you may have come across. And we were obviously paying attention, but also finding time to chat. And I don't remember now which of us said it to the other, we were both thinking at the same time. Every speech from the opposition said youth unemployment is far too high, and it's the government's fault. And every speech from the government side said youth unemployment is far too high, and it's the last government's fault. And nobody from any side was saying anything about what do we do about it. And it's frustrating, and I don't want to see what happens far too often in some of these party political fights, that it's about it's your fault, it's your fault, it's your fault, let's fix it. Let's not argue about that. So as I said, it's a hugely key issue, and it's clearly utterly unacceptable we have these sorts of health inequality differences. I mean, there's no way they can be acceptable anywhere. There's one of the famous figure that as you go, every step you go on the Jubilee line away from Westminster costs you a year of your life. You know, how is that acceptable? I think the gap in Glasgow is 14 years, something like that. How is that possibly acceptable? It's even worse overseas. You know, that we're talking here about inequality within Cambridge, but actually the fact that there are people in countries around who have much shorter life expectancies is also utterly unacceptable. And for me, this is again a slightly core philosophical point. I'll just diverge slightly. I'm very much a Rawlsian liberal. I don't know if you all know Rawls. I haven't read any sort of everything he did. But there's one idea which I love, and apologies if you were listening to Radio Cambridge here at 6:20 in the morning a couple of Sundays ago, you'd have heard me on the Faith programme talking about this. Any takers for people who are up at 6:20? No, I don't think so. It was pre-recorded. But there's this wonderful idea of a veil of ignorance that Rawls came up with. And that is, how do you work out what a fair, just society would look like? And his idea was that we would all gather together before we come into the world, it's a bit of a conceptual thing, it's hard to actually do, and work out what is fair and what isn't fair before we know who we will be. So before you know whether you'll be male or female, whether you'll live here or in Syria, you know, whether you'll come from a rich family or a poor family, before you know any of that, we work out what will be a fair system. Would anybody think it was okay that you might randomly be drawn for the you'll die early card? There's no way that we do it. So it's clearly not a just thing to do. And the problems in Cambridge, as this wonderful report really sets out clearly, are just too bad. You know, anything that is worse than no life expectancy difference between ward areas like that is just, in my view, unacceptably bad. We won't have everybody living exactly the same amount of time, but the averages by areas, there's no reason why wealth should get you extra years of life. There's no reason why wealth should get you extra years of healthy, non-disabled life. There's just no reason for that. In my day job at the moment, I'm an academic at the University of Cambridge looking at public policy, and we do some work with YouGov, and we had a conference recently about inequality, which was fascinating. Stuart and I were chatting there, so he'll know what I'm about to say, and we've done some surveying of people and what they think is acceptable. But it's quite clear that most of the public do not think it is acceptable for there to be a life expectancy gap that's based on that. Good. The public are on side on this, they're not on everything. And it becomes even worse. It's not just that how long you live is related to where you live. Because we have such a huge problem with social mobility, and have done for many, many decades and centuries, how long you live depends on where your parents lived. You know, we get into this vicious cycle which traps people. At birth, people are being dealt with poorly simply because we have an unfair system. We absolutely have to break that. It applies at every single level. If you're born in a poor area to a poor family, you generally get less good education. You get less good education, you get less good prospects, and so on. It keeps cycling. We have to change that, we have to fix that. And to do that, just to come back to the issue about health itself, I can talk about education for a while, but that's another subject we might want to talk about later. Part of the challenge, and part of the whole point of the Marmot work, is that you have to go broader than just looking at health, as it's been classically considered. And Michael did a Desert Island Discs, which was really quite interesting, where he talked quite a lot about this. It's worth listening to. And he described the experience of having patients come in, and he'd patch whatever the short-term problem was, give them antibiotics or whatever, and then send them back to unacceptable living conditions. He felt it was getting pointless just to sort of go through the medical cycle. So yes, we have to make sure that health is delivered in an equitable, fair way. Actually, we have a lot to be proud of here, because the NHS is rated, certainly in the last survey I saw, as the most equally accessible health service anywhere in the world. Better than Denmark, better than anywhere else. You know, no matter how much money it is, you have access. That's brilliant. We have to keep that. That's one reason why I get very annoyed when I see some of the stupid suggestions from various politicians, sadly left and right, that we should start charging for access. As soon as you do that, we'll lose that ground. Like, you know, I'm so proud we have an NHS that everybody can go and use. But any intervention that's done at that stage is almost too late. I take the risk of being corrected by Tony, but probably one of the biggest things that helped with health was proper sanitation. That's not something which a doctor would do. It's not what you'd technically say is the Department of Health's responsibility, but it saved more lives, made more difference than anything else. That's where you have to look. And that is exactly the point about Marmot. So it's about social services. I used to be on the county council, and one thing which I found really annoying was there's been pressures in budgets, you know, every single year. From 2001, there was always not enough money and so forth. And what would happen is that time and time again, the work would be focused just on the people in the highest need. And when you do that, you start focusing on people in the highest need. You don't help the people whose needs aren't so bad at the moment. You wait until they get to a really high level of need. So it ends up costing you much more, as well as being much worse for them. Why would you do something which is worse for people and more expensive? You know, utterly absurd way to do things. So we have to try to get more into prevention, getting social services to help people as early as possible. Help people. There are ways of empowering people so they can look after some of their conditions earlier before it's necessary to do bigger, more expensive things. And sometimes you just have to provide more support that is going to cost more, but let's try to reduce the need for that. Housing is a huge issue. We've already heard quite a lot from Stuart and Tony about housing, and it's absolutely true. People in poor quality housing, and we do have far too much poor quality housing around Cambridge. Some of the council stock, some of it's now being knocked down and replaced. Utterly atrocious quality. And I've been into places around Cambridge which you can see why people are not healthy when they live in them. Big problem now in the private rented sector. There's been some steps to try to improve that, but there is still parts of the private rented sector that are just simply not fit for people to be living in this sort of time. And problems with people being overcrowded. All of those problems make things worse. The living wage was touched on as well. You know, hugely important to make sure that when people are in work, and I agree with everything that's been said about it's not true that people who are poor are the ones who don't have jobs. Not having a job is not a helpful thing, is it? But let's make sure that people can actually earn a decent amount. The idea was talked about all the way about citizens' income, which is something I'm actually very interested in. I think I'm doing some work with various people at the moment to try and look at ways of making it all work, because it is important to get it right. There's been some interesting pilots, but I think it is going to be the right way forward. Again, how technology will start to change employment is another subject. I don't have time to bore you on that right now. The Whitehall 2 study, another of Michael Marmot's pieces, one of the things that came out of that was that one of the biggest factors that makes people unwell is stress, is insecurity, is lack of control over their own lives. So anything that makes people be insecure, whether that's insecure unemployment, insecure housing, anything else, is hugely deleterious. Mental health is another big factor. People with mental health problems, we know that 1 in 4 of us will have a serious mental health problem at some point in our lives, but for decades, centuries, generations, we've just sort of ignored it and sort of, oh, you're depressed, oh, well, try and be happy. It doesn't work like that, and that causes huge problems. I think there's also an issue that too many doctors and people in medical professions really look at health as being defined by ill health, disease, and actually much more about helping people to flourish, helping so that people aren't on the border of disease, but have moved a long way back. We can change the way that works. I think there's also a big factor about how we judge success in society. I've probably spoken for too long, so I won't say too much about this, but and again, this was a 6:20 in the morning programme on another week. We have this national obsession with GDP. And GDP is an atrocious measure of anything we should actually care about. If we were to smash this room up, I'm not suggesting we do, and then it gets fixed, GDP has gone up. Is that in any sense a good thing? If you develop lung cancer and get treatment by the NHS, GDP is higher than it would have been if you'd never developed the lung cancer. How's this a good thing? The big BP oil spill contributed massively to GDP, global GDP, because all the costs of cleaning it all up again. It'd be much better if it never spilt in the first place. GDP is utterly the wrong measure. So something I spent 5 years trying to push on was the idea of looking at well-being economics. Let's look at things that actually matter to people's lives. Make people's lives count, not GDP. GDP is also very unequal and unfair because it means that if you take £1,000 away from somebody who has very little and give £2,000 to somebody who's already a millionaire, GDP's gone up. I think most of us would prefer it to go the other way around, and that would have more benefits to people's lives. I can do another 10 minutes on that, but I will spend. I was asked to talk about what the CCG can do, so I will actually do what I'm told to do. And the CCG has only limited ability to do things. So, for those of you who don't know what a CCG is in our bizarre system, we fund secondary healthcare across Cambridgeshire and Peterborough. So we spend about £1 billion hiring Adam Brooks, hiring various other people. We don't directly commission public health. That's done by the councils. But there are some things that we do. I want us, as I've been pushing for, to look much more about improving access to the NHS services, particularly in some of the more rural areas of Cambridgeshire, where it may be that you'll get free treatment if you can get there, but if you can't get there, that doesn't help very much. And putting more resource into GP surgeries and other things in areas where there is high deprivation. But that's only part of it. I think a lot more is that preventative agenda. We talked about health prevention. There is a Cambridgeshire and Peterborough health prevention strategy. My view, and I've said this publicly before, is I don't think it's anything like ambitious enough. There are resource constraints on the NHS. We need more money. And money is being saved in all the wrong places. Money is being saved by, for example, not giving nurses the pay rise that the independent panel said they should get. That's the wrong way to save money. I would much rather save money by, for example, intervening early to help people not need dialysis. There are loads of things within the NHS where we could save money and actually make people healthier. That, I think, has to be the way forward. The other thing within the CCG that is a huge passion of mine is mental health. And mental health is a huge cause of some of the problems that we have here for mental health. Just to give you an idea, when I joined the CCG, the waiting time for child and adolescent mental health was 47 weeks. I have annoyed, I think, all of my colleagues on it by banging on about it at every meeting. And thanks to their good work, I'm a non-executive, I don't do this, it's now down to about 14 weeks. That's still too long, but 14 weeks is a lot better than 47 weeks. So the CCG can do a lot in those areas, but what it has to be about is looking at the whole system. One of the things we're just doing now, it's just gone on our website, is having a much larger plan across Cambridgeshire and Peterborough to work with the council to work with all of these facilities, because the best way to reduce health inequalities is to make everybody better off, to alleviate these problems, to fix the challenges. So I'm really pleased that we have this report. I'm really pleased that people are talking about it. It's a shame there aren't more people here. but it's something which I hope all of us will keep talking about. And it would be lovely to keep seeing you, hopefully for not too long, until we get the lists down, and we can start to say, actually, health inequality is something more of the past. I think we'll be seeing each other for a few years yet, sadly.
I work in the high-tech sector, and you'll talk about the NHS being a great enabler of free access. Actually, no one I know above a certain professional level would take a job without private health insurance, and that lets you jump the queue enormously with a certain category of illness. And that is a massive inequality.
It's not as bad here as in many places. And so I do know people who are well paid who, as a matter of course, use the NHS. So, as an MP, I thought I was well paid. I wasn't well paid by a lot of times. I would never even dream of getting private cover.
It's part of the job.
Well,
most companies are.
but I think there is a problem if people start separating themselves, and the whole universalism becomes a really big factor. People don't feel part of it. But actually, people do feel part of the NHS, even people who do have, I think, cover.
It's causing harm, but they still could get treated better.
Yeah, I mean,
You increase inequality.
agree. We'll see about Theresa May. It's a bit early to be certain, but I have my sensations. I haven't yet heard her announcements about allowing housing associations not to be forced to sell homes, for example. There's some argument, it'll be interesting to see whether it works, and I genuinely don't know, that so much of public health is about fixing people's environments, that actually having the people doing public health with the people who are doing the stuff about the environments helps. So there is a challenge. How do you have public health in the health bit? But also, and it works better in single-tier authorities, I think. If you want as a public health person to do something about housing, working in the same place as the person who does stuff about housing is going to give you that chance to say, now hang on, have you thought about these things? But as soon as you're in a different agency, you've seen this, getting people to actually talk at the right times is hard. So I think the problem wasn't so much that move, that there are problems and benefits from it. It's the fact that it's not protected. And actually, investing in public health has huge returns. And nobody really recognises it. If you look at the 5-year forward view for the NHS, there's a whole set of flaws with that. The amount of money they reckon that can be saved by health prevention is minuscule. It's just not a focus. But we all know that actually you can save huge amounts of money. There's a famous case, I don't remember where it was, 10 years ago I think, where a PCT spent some money on gritting pavements and got a lot of flack for wasting health money. And their point was, well, but it's cheaper to grit the pavements and not have people fall over, so we don't have to fix their legs up. I say, well, but it's the local council's job to do that. It's like, yeah, but they weren't. It's still cheaper. And we have to get that sort of thinking, because too often expenses in one bit of the public sector save money in another bit of the public sector, and nobody fits it all together. New housing, as it's built, needs to make sure to mix communities together. And I always feel upset when I see a housing area where it's like all the expensive housing here and the affordable housing, if there's enough of it, over on that side. Always looking a bit cheaper in a slightly nastier area. I want to see mixed communities because, as I understand it, the people who live there are all going to be human. And let's treat it like that. And there's one of the estates around Trumpton, I can't remember which one. The ones who are on the same side as the John Lewis bit was, where the only difference between the social houses and the non-affordable houses is it's the Meadow. I lose track of the names of all the different bits. The only difference is that all of the social housing has solar panels, and only some of the private housing does. And I just think that's actually what we shout that you don't. It's okay to have your house next to somebody who has a different income, but you're still human. And I'd like to see that sort of thing, because actually that would mean that we would have less segregation of people. You discover that yes, everybody is in fact a human.